Hi friends, I am Dr. Pramod Zog here from Pune, and we are going to discuss about allergic disorders in children and about a new molecule that is belastin. And to discuss about this topic, we have two colleagues of mine, good friends of mine, Dr. Prashant Moralwar from Navi Mumbai. He is a senior pediatrician and the past president of the Navi Mumbai branch of IAP. He also has his own hospital set up in Khargar and CBD Belapur. And I know that he was instrumental in setting up the IAP office in Navi Mumbai. We also have Dr. Sanjay Nathu, who is the professor of pediatrics at the Navle Medical College, the Simvagad Medical College, and he is also a pediatrician at the Shashwat Hospital in Kothurud, and he is the president of the Pune branch of the Indian Academy of Pediatrics, and both of them are academically scholars. And we will discuss about the topic of allergic rhinitis, and the topic is particularly relevant because allergic rhinitis, the incidence of this particular disease, the prevalence rather, is day by day on increase, and quite a few children, basically during the COVID times, they did not have the problems related to infectious diseases, but the other problems in the environment like the pollution, then the indoor allergens, because many of these children were indoor, and that's why the dust mite and the other indoor air pollutants, they have been all there, and that's why allergic rhinitis has really not gone down, and it is as it is. So we need to know a lot of things about allergic rhinitis and other allergic disorders. Another important thing is that belastin is a new antihistaminic agent, which is a very safe molecule and a non-sedating antihistaminic, and we should know about it. And the third and the most important thing is that allergic rhinitis is an important comorbid along with asthma in children. So many of us, they keep treating asthma, but the control is not there. And that's why in a child who has uncontrolled asthma, many times allergic rhinitis is forgotten as a comorbid. Okay, 80% of children who have asthma, they have allergic rhinitis as a comorbid. And for all these reasons, it is necessary that we know everything about allergic rhinitis. However, today's focus is on antihistamines. And to begin with, I will just give you some case scenarios. This is the first case, and she is a girl, 11-year-old, with history of recurrent cold since 6 months. And she has paroxysmal sneezing, and the sneezing is more than 50 times in few minutes. There are, of course, many people in the audience also who start sneezing in the morning, and one of my close relatives usually acts like an alarm in the morning. Even if I do not want to get up at 6 in the morning, I have to get up because this gentleman starts sneezing and sneezes 50 times in a minute. And then this is typical allergic rhinitis. Okay, and these symptoms in some patients, they worsen in August or September. This we call as seasonal allergic rhinitis, while there are a few who have allergic rhinitis all throughout the year, and that is mainly because of the indoor pollutants, the dust mites, then the floor cleaners, then the, so many problems are there inside the house, which we will discuss in a minute. So this is a case of allergic rhinitis, plain simple allergic rhinitis. Another case is a girl, 4-year-old, with cough and cold, which is off and on, but almost persistent for the last 3 weeks. And the fever and headache have been there in addition for the last 4 days. Now you can see that the difference is that this particular girl has fever and headache, and the cough is more in the lying down position. So obviously our listeners, they now know that this is likely to be sinusitis because there is fever and headache. Another child, a 5-year-old boy with history of cough, cold off and on for the last 3 months, with history of fever and pain in the ear 2 months back. This subsided with a course of antibiotics, but the cold and the cough do not go away. It's always there, and there is no breathlessness. So this is a chap who has a problem along with allergic problem. He has some problem related to the ear, maybe otitis media. And then the last case number 4, is a 3-year-old boy with severe cough, cold and sneezing for the last 15 days, and it has been recurrent for the last 4 months. And the practitioner has given him a course of antibiotic. And as you know, nebulization has become a welcome drink. Every child coming to the clinic, as soon as the parents say the C of cold or C of cough, the child is taken in front of nebulizer, which is not a very good state of affairs. And the child, of course, received cough syrups for 5 days, but the response is not very good. There is no fever, but cough and cold persist. There are no chest signs, and someone has put him on an inhaler for the last 5 days, and the patient has come to you for a second opinion. So obviously, it means that there is an element of asthma in this particular child. And why I told you all these 4 cases is because the patients come to us with the symptoms which are all common: recurrent cough and cold. But there are some additional pointers which are different in each patient. Okay. And these confusing symptoms should be dissected out and they should be analyzed. And that's why careful history and examination in a child is extremely important. Otherwise, to diagnose allergic rhinitis where there is watery rhinorrhea and there is itching of the nose, all this is not very difficult for a learned pediatrician. But to identify the associated problems, the comorbidities, is very important. And that's why it's necessary to differentiate between allergic rhinitis and infectious rhinitis, that is common cold. We will see that in a minute. We should also try to find out whether there is associated sinusitis. Again, sinusitis, whether it is allergic or viral or bacterial. We also should find out whether there is associated enlargement of the adenoids. This we can find out by asking the question whether this child keeps the mouth open and also snores at night, where there is otitis media, and all these problems along with a comorbid with asthma, we need to remember, because the treatment plan will change accordingly. And that's why the symptoms which are suggestive of allergic rhinitis are watery rhinorrhea, sneezing, which is paroxysmal. Paroxysmal means today in the morning, this particular child will sneeze 20, 30, 40, 50 times. Then till 12 noon, 12 afternoon, no problem. Again, maybe in the afternoon, again, the child will start sneezing. So that's paroxysmal. Then there will be nasal itching and there will be nasal obstruction in a few children, which is many times nocturnal. So in case if 2 or more of these symptoms are present for more than an hour on most of the days, then these are the symptoms which are suggestive of allergic rhinitis. But there are some symptoms which are not associated with allergic rhinitis, particularly unilateral symptoms. Okay. If there is a discharge only from one nose, we know that it is likely to be a foreign body. Okay. If there is only nasal obstruction, no rhinorrhea and no sneezing, no itching, then it is less likely to be allergic rhinitis. If there is mucopurulent rhinorrhea and there is posterior rhinorrhea, that means a post-nasal drip with thick mucus, and there is no anterior rhinorrhea, then it is also not likely to be allergic rhinitis. And if there is pain, recurrent epistaxis, anosmia, all these features are the ones where one should refer to an ENT surgeon. And as I was going to tell you the differences between common cold and allergic rhinitis, common cold is usually infectious. We know that rhinovirus, adenovirus, influenza virus, parainfluenza virus, all of them, they produce common cold, and it lasts for almost a week. Usually there is associated fever and constitutional symptoms like body ache, headache, along with fever. And the nasal mucosa in these children is red, and they may not respond to antihistaminics, or they may, but the response is not definite. And the most important thing is that along with the family member, other family members are also affected. So this is common cold, which is usually viral. On the other hand, allergic rhinitis, the cold will last for more than 10 days. There won't be fever. There is no reason for the child to have fever. There will be allergic signs, which I will tell you in a minute. The nasal mucosa will be pale, and the child will show a very good response to antihistaminics, and only that particular child will be affected and not the other family members. And there could be symptomatic clues which are beyond the nose, particularly in the eye. So there will be watering of the eye, itching of the eye, redness of the eye. This is allergic conjunctivitis. And the molecule belastin works very well. In addition to allergic rhinitis, it also takes care of allergic conjunctivitis. Okay. This particular child is also likely to have eczema, that is atopic dermatitis. There is likely to be fullness of the ear, and there could be pruritus of the palate. You must have seen quite a few children who come to the clinic and they will produce a peculiar sound as if there is some itching on the palate. Okay. And I already told you about some comorbidities. That means the morbidities which coexist along with allergic rhinitis and the complications. So to repeat, sinusitis, which will be indicated by headache, a very bad breath, and cough in lying down position. These are important symptoms. I remember my teacher used to tell us that a person with sinusitis will produce a very bad breath, that is halitosis. He himself will not be able to smell himself. Okay, that's the big problem. So for others, he is a big trouble. Then if there are enlarged adenoids, there would be obstructive sleep apnea with snoring, mouth breathing, and there would be hypernasality of the voice. And if there is otitis media with effusion, then one has to be on lookout for that. And there could be asthma, which is uncontrolled because the allergic rhinitis is not controlled. So I told you the four major cardinal symptoms of allergic rhinitis: sneezing, itching of the nose, rhinorrhea, and congestion. Now, all these symptoms are related to histamine. And where does this histamine come from? That comes from the reaction. Now, what is that? We will understand it better if we see the definition of allergic rhinitis, which is a chronic inflammatory disease of the nasal mucosa, which is induced by IgE antibodies after exposure to allergen. So all these important words you have to remember. Suppose there is a pollen outside in the atmosphere. This pollen will act as an antigen or an allergen, and initially it will induce the IgE antibodies. There won't be any problem when there is first exposure, but when there is a second exposure, okay, at that particular time, again these IgE antibodies will be produced, and when there is cross linkage, these IgE antibodies which are sitting on the mast cells will make the mast cells release histamine, and histamine is the main thing, main culprit behind allergic rhinitis, urticaria, and so many things. We will see about it in a minute. And the children affected with allergic rhinitis are about 5 to 25%. And this is a very famous graph which tells you the march of allergy. This is seen in children who are atopic. Atopic means they have a tendency to get the GI manifestations in the first year of life. In the first 6 months, they will have, say, cow's milk protein allergy, which usually slowly disappears as the age advances. Some of them might have atopic dermatitis, which also slowly disappears. But asthma, which comes up as a preschool wheezing in children somewhere in the age group of 2, 3, 4 years, which continues. And allergic rhinitis, which starts little later after 3, 4, 5 years, and then it may continue all throughout. Remember, it's a disease which is only controllable but not curable. And one has to know this particular prevalence of symptoms according to the age. This is a very important graph, and that's why, to recapitulate points about allergic rhinitis, when you ask the history, ask for runny nose but clear watery discharge, paroxysmal sneezing, nasal itching, associated nasal block, watering of the eyes, itching, redness, atopic eczemas, asthma-like symptoms, and family history of allergy. So when a patient comes, see that you ask all these points in the history, and then also look out for certain signs. Now this chap is having itching of the nose with rhinorrhea. This particular child has allergic shining. That's a shiner because of the venous congestion under the eye. This chap has a transverse crease at the junction of the nasal bone and cartilage. And this child has allergic salute because he is trying to, satisfy the nose. Everyone in this world has his own way of satisfying the nose, and this chap has allergic salute. Okay. Now, allergic rhinitis symptoms are grouped into two. There are sneezers and runners. That means those who sneeze and have a runny nose. So they have a paroxysmal sneezing, watery anterior rhinorrhea, nasal itching, conjunctivitis. And this is worse during the day, but improves at night. While blockers are the ones who don't have much of sneezing, but the mucus is thick. There is severe congestion and it's worse at night. And the area classification, that is the allergic rhinitis and its impact on asthma. So this particular classification classifies allergic rhinitis into 4 categories. There are some who have a problem which is intermittently. So it may be in the month of February, then again in the month of April, then again in the month of August or September. So that is intermittent. Or as I told you, sometimes it is persistent. And the figure 4 is very important. So if it is less than 4 days in a week, and if it is less than 4 weeks in a year, it is called intermittent, while more than 4 days in a week and more than 4 weeks in a year, that is called persistent. And both these varieties could be mild or moderate to severe. Mild meaning thereby the sleep is not disturbed and the activities are not affected. The child goes very well to the school next day, he is okay. While the moderate or the severe category, the sleep is disturbed and the activities are affected. So the antihistaminics have a major role to play in this particular quality of life also. And the most important is the control of the environment. There are certain important terms. For example, the ones which are in the outdoor, I told you about the pollens from the tree or the grass or the weeds. They are the outdoor triggers, while indoor triggers are mainly the house dust mite, which is seen on the blankets and chaddars and others, while the fungal molds inside the house, on the wet walls, the pets like the cat and the dog, the cockroaches inside the house. So all these are the indoor ones. If you see, these are almost all the living agents. But there are irritants like cigarette smoke, the smoke coming out from a mosquito coil, cooking fuels, air pollution. These are non-living items. They are not called allergens, they are called as irritants, so they will aggravate the problem. Okay. And remember that the avoidance of environmental triggers is extremely important. There are some fathers who take pride in using different types of perfumes like Chanel from France and others, but then sometimes the poor little child is allergic to this Chanel, and then it is a big problem. But it's an irritant, it's not a trigger. Okay. And remember, the management of allergic rhinitis obviously includes the control of the environment and the use of drugs. Now, the drugs could be oral or they could be intranasal steroids. We will see a few aspects of some of these important modalities of therapy. However, today's focus is mainly on the antihistamines. Immunotherapy is used, but it is rarely required. And the management of allergic rhinitis is a stepwise approach. If you see at the bottom of this particular slide, remember that the antihistaminics are required in all these 4 categories, and avoidance of allergens is also important in all the 4 categories. However, the intranasal steroids, then the leukotriene receptor antagonists have their own place in certain types, and immunotherapy, as I said, is required in very few patients. I will not discuss about management of allergic rhinitis in details. This will be done later on in Dr. Nathu's talk and Dr. Moralwal's talk. I will just give a brief account of associated problem of sinusitis. So I will just tell you about the comorbid. One of them is allergic rhinitis and the impact of asthma. This is important because allergic rhinitis alone can be diagnosed, as I said earlier, but 30% of allergic rhinitis patients have asthma. And as I told you, 80% of asthmatics have allergic rhinitis. And allergic rhinitis is a risk factor for asthma. Both of them, they share common allergens. That's why the concept of unified airway disease, the same problem, that means the same pollen, the same house dust mite will create allergic rhinitis. It will be also a trigger for asthma. And that's why proper treatment of allergic rhinitis will improve the asthma control and the pulmonary function tests. You should also know a bit about allergic sinusitis, because rhinitis and sinusitis, they coexist, they are together. That's why the correct term which is used, it should be rhinosinusitis. And the symptoms are nasal blockage, nasal discharge, which is anterior plus posterior, because sinusitis means posterior. Okay. And halitosis, that is bad breath, and loss of smell when there is rhinosinusitis. And as there is sinusitis, there will be facial pain, headache, and ear pain. X-ray of the sinuses is not very specific, and the mucosal thickening could be either allergic or maybe because of viral or bacterial. And the CT of the sinuses gives greater details but does not guide about the etiology, and it's expensive. And the treatment of allergic sinusitis is same as allergic rhinitis. However, one should remember that there could be bacterial complications, and a child might get bacterial sinusitis when the discharge will be thick, mucopurulent. There will be post-nasal drip, and it will be persistent for more than 10 to 14 days. Okay. The child simply doesn't recover from the cold, and the child gets fever, headache, facial pain, and there will be cough in lying down position, and he needs treatment for 14 days. Remember, no treatment of 3 or 5 days, and the underlying allergy should be kept in mind. If there are problems like a severe deviated nasal septum, which is creating obstruction to the nostril, or a glued ear, or a refractory sinusitis with adenoid enlargement, or obstructive sleep apnea because of adenoids, and nasal polyps which are not responding to the intranasal steroids, then you have to refer them to the ENT surgeon. A few points about allergic rhinitis: look out for the cardinal symptoms, watch out for the comorbids, particularly asthma, ocular allergy, adenoid hypertrophy, rule out or treat infections, and use the antihistaminics and the intranasal steroids depending on the severity. Treat allergic rhinitis so that it improves asthma control, and rarely you will have to use specific immunotherapy. One should also know a bit about urticaria. Remember, urticaria could be acute or chronic, and acute urticaria is the one which is less than 6 weeks, and beyond that we call it as chronic. And there could be some physical factors. We have seen so many children, after taking a bath or after they come drenched after the rains, they get urticaria. So these are physical factors. So there are cold urticarias and so many other pressure urticarias. There are some children who have allergy to food, and they get lot of big blotches which are called as hives. Okay, and this is because there is involvement of the dermis. Plain simple itching is epidermis, while if there are hives means big angioedematous patches. I know of my residency days, remember, where there was a child who came for swollen lips with almost choking of the breath, and this child had very bad cough, and I had given him only antihistaminics. And then one of my senior teachers, when he came for the rounds, he said that this is angioedema, you cannot simply give only antihistaminics, you have to give adrenaline. And my dear friends, that's why, remember, whenever there is a problem like this, adrenaline is the drug of choice. Okay, many of us, they are fond of giving some antihistamines in the injectable form along with steroids, but that not the immediate treatment. So remember that there are some conditions where you can have problems. For example, penicillin, whenever there is allergic reaction, all these problems can come up. I also remember many of my friends who go to the Apoli or some beach where children, they go into the sea just for the fun of it. When they come back, there is severe itching, probably because of some bites or some other problem. So you have to be very, very careful. And whenever you go for any outing onto a sea beach or any other place, always carry injection adrenaline, some injectable antihistamine, and an injection of a steroid with disposable syringes. Remember that, it's very important. So we will discuss more about urticaria in this particular session. I just wanted to introduce this particular topic. Remember, the main important thing about urticaria is transience. Urticarias are transient. Okay, so remember, that is the most important feature. And there are children who are allergic either to the milk or the soya or the fish or the egg or quite a few other food products, but these are the ones which are common. And I already told you about allergy to certain drugs, particularly penicillin. So with that, I will just stop sharing my presentation, and I will request Dr. Sanjay Nathu to start with his presentation. He will give you some information about the molecule bilastine. So it's over to you, Sanjay. Thank you.
Thank you, Jog sir, for involving me in this discussion. So let me just allow to share my screen. So can everyone see my screen? Jog sir, is it visible?
Yes.
Thank you. So let me begin. Once again, thank you to Jog sir. So let us discuss about the antihistamines, which Jog sir has said are a very important part in management of allergic rhinitis as well as urticaria. Now, it was Sir Henry Dale who in 1910 discovered histamine, which is such an important molecule in the process of inflammation. And it was not until 1940s when Bernard Halpern synthesized the first clinically usable antihistaminic, that was a fenbenzamine. So antihistamines have been in clinical use for 70 years, as you can see in the figure, starting from fenbenzamine, subsequently chlorpheniramine and terfenadine and so on. And these agents have been evolving a lot with time. So very important part was the progress in the development of antihistamines from the first generation to the second generation. So what was the problem, or what were the changes which were there between the first and second generation antihistamines? So the first generation antihistamines tended to be non-selective and they had a lot of anticholinergic effects. As a result of that, side effects like agitation, psychosis, mainly sedation, sometimes seizure, rarely hypertension and tachycardia would also occur. Also, there were some alpha-adrenergic effects which would lead to dizziness, and rarely there were anti-serotonergic effects which led to increased appetite and weight gain. Now, the first generation antihistaminics like the chlorpheniramine, maleate, and diphenhydramine had to be administered 3 to 4 times a day because of the short half-lives. They also tended to cross the blood-brain barrier very easily, giving rise to central effects which were not what was indicated or what was required. So the potential for causing side effects in the form of sedation, hyperactivity, insomnia, and so on, psychosis and agitation was very high with them. They could also cause some other side effects due to their alpha-adrenergic activity, for example, prolonged QT interval. There were a lot of drug-drug interactions involved with this first generation antihistaminics, and hence they had a lot many problems when used. With the development of second generation antihistamines, some of these problems were overcome. So one of the prime problem was the non-selectiveness. So the second generation antihistaminics are selective only for H1 receptors. Now H1 receptors are present in nasal mucosa, endothelium, lung, lymphocytes, etc. And they were involved in bronchoconstriction, vasodilatation, and so on. The H2 receptors are mainly in the gastric mucosa, H3 are in the CNS and the GIT, and H4 are in the hematopoietic stem cell, colon, heart, lung, so on. So the second generation antihistamines have a selective action on the H1 receptors where their action is mainly needed in most of the clinical conditions. The other advantage was they could be administered only once or twice daily because they had a fairly long half-life. The third one was they did not cross blood-brain barrier, or they crossed the blood-brain barrier to a very small extent, and hence there was very less amount of sedation, or sedation occurred only at a very high dose. Similarly, they were not involved in other adverse effects like the QT prolongation, neither did they have too many drug-drug interactions. And we all know the examples of the second generation antihistamines, starting with cetirizine, subsequently levocetirizine, fexofenadine, and now, of course, bilastine, the new kid on the block. So all these have good binding or good affinity for H1 receptors, faster action and longer duration of action. They also help in reduction of ocular symptoms and very less or no sedation at all. So these are the advantage of the second generation antihistamines. So what are the characteristics of an ideal histamine? So if you look at the pharmacological properties, we want them to be potent and highly selective only for H1 receptors. We do not want any other clinically relevant pharmacokinetic interactions with food, medication, or intestinal proteins. We do not want them to induce the cytochrome P40 and 450 enzyme system, thereby avoiding drug-drug interactions. And we don't want them to have interactions in other diseases, thereby avoiding toxic reactions. As far as the pharmacodynamics is concerned, we want it to have a rapid onset of action, a longer duration of action, providing a once daily dosing, and no potential for tolerance development, that is tachyphylaxis. So just to give an example of tachyphylaxis in a newly married couple, if the husband starts seeing TV or matches on TV, the wife would tell him, "Ki baba te TV band kar, apल्याला बाकी गप्पा मारायच्यात, बाहेर जायचं फिरायला." After a while, after a month or so of this continuous nagging, the husband will start to neglect the better half and will keep on watching the TV. So this is what is tachyphylaxis. So after a certain limit, it develops a tolerance. So this is what we don't want in an ideal antihistamine. As far as efficacy is concerned, it should be effective in both intermittent and persistent allergic rhinitis. It should be effective against all nasal symptoms, including obstruction as well as ocular symptoms. And studies should be conducted in young children and elderly patients to assess efficacy. So you know nowadays the problem with these vaccines, there are hardly any studies or no studies at all in young children, and hence they cannot be used in young children. I'm talking about the COVID vaccines. So for an ideal antihistaminic, we want studies to have been conducted in young children as well, so we know they are safe and efficacious. We don't want an ideal antihistamine to have any major side effects like sedation or cognitive or psychomotor impairment. We don't want any anticholinergic activity, no weight gain, no cardiac safety concerns. They should be safe for use in pregnancy and breastfeeding. And again, studies should be conducted on children, and also post-marketing surveillance should be conducted so as to assess the safety. So this new kid on the block, Bilastine, which is a new generation antihistamine, it almost satisfies most of the criteria of an ideal antihistamine. It is a modern, non-sedative, second generation H1 antihistamine, which has the highest number of desired features for a modern antihistamine according to the international guidelines. The structure of the bilastine that is characteristic because it has a hydrophilic carboxylic substituent, and this is important because it contributes to the low penetration into the CNS. Now there are brain H1 receptors in the brain, that is the H1 receptors in brain, and there is something called as H1RO, that is brain H1 receptor occupancy. So the non-sedating antihistaminics have an occupancy less than 20%, the less sedating have 20 to 50%, and the sedative have more than 50%. So because of this particular structure of bilastine, it has a very low occupancy of the brain H1 receptors, and hence it does not have any penetration into CNS and very low sedation. So bilastine has been approved by the DCGI for symptomatic relief of allergic conjunctivitis, seasonal as well as perennial, as well as urticaria. Bilastine is, as a second generation antihistamine, is one of the first line of treatment in urticaria, as recommended by the European Academy of Allergy and Clinical Immunology and the World Allergy Organization guidelines for the management of urticaria. So this molecule has been approved by DCGI as well as international associations who are dealing with allergy and immunology. Bilastine was approved for use in the European Union in 2010 and is currently being introduced into clinical practice in 28 countries in the European Union, especially for treatment of allergic rhinoconjunctivitis, as Jog sir was saying. So this rhinoconjunctivitis go hand in hand, and bilastine works well in both these situations. As far as the pharmacodynamics are concerned, it is an H1 receptor antagonist, has an anti-inflammatory effect. It is a highly selective H1 receptor antihistamine, and it has 3-fold greater affinity than that of cetirizine and 5-fold greater affinity than that of fexofenadine. So we previously used to use cetirizine, then subsequently levocetirizine, now fexofenadine we have been using, but bilastine has even better affinity to the H1 receptors as compared to these molecules. On top of that, bilastine has a long drug target residence time at the H1 receptor, and this results in a prolonged H1 receptor antagonism in vitro. So a prolonged action, a prolonged H1 antagonism has also been seen with bilastine. So if you look at the pharmacokinetic parameters with a dose of 20 milligram orally, the maximum concentration is between 180 to 256 nanogram per ml, and the Tmax, that is the maximum action, is seen in about 1 hour to 1.5 hours. Bioavailability is 61% and half-life is about 14.5 hours, so quite a long half-life. So we can use it only once daily dosing. There is minimal metabolism in liver, and excretion occurs in urine and feces. So this minimal metabolism in liver helps us because then it can be used in liver diseases as well, and there is hardly any metabolism in kidney, so it is safe in kidney diseases as well. Bilastine has been studied in children at a dose of 10 mg once daily, and it is licensed for symptomatic relief of urticaria in children more than 6 to 11 years in European Union in appropriate formulation as an oral solution or an orodispersible tablet. So 6 to 11 years with body weight of at least 20 kg, the dose is 10 milligram, that is 4 ml of oral solution OD. Indications are symptomatic treatment of allergic rhinoconjunctivitis, seasonal as well as perennial, and urticaria. It is also indicated in adults and adolescents, that is more than 12 years of age and over, and the dose there is 20 milligram. As I was talking about, bilastine has a brain H1 receptor occupancy which is near to 0. And if you can see in the graph which is accompanying this slide, the bilastine, the olopatadine eye drops, and fexofenadine at a lower dose have this very low H1 receptor occupancy. So these have very low sedation because of this property. Several studies were done on bilastine, and a safety and tolerability study was done on bilastine 10 milligram administered for 12 weeks in children with allergic diseases. This was a phase 3 multi-center double-blind study. From 2 to 11-year-old children were included, and the indications were allergic rhinoconjunctivitis. The test group received bilastine 10 milligram oral dispersible tablet, and there were 260 in this group, and the other group received placebo. that is 249 subjects for 12 weeks. And if you can see the accompanying graph, there is the assessment of somnolence and sedation from baseline on 4 parameters. That is the sleeping related breathing disorders, daytime sleepiness, snoring, and inattention. And all of these were comparable to placebo. So whatever effects were seen were just the same as placebo. And hence bilastine joins cetirizine, levocetirizine, and loratadine as second generation H1 antihistamines approved for use in pediatric patients for which long-term safety data are available. So in this trial, they were used for 12 weeks and there was hardly any problem if you look at the effects as compared to the placebo. Bilastine versus cetirizine and fexofenadine was studied in allergic rhinitis in a Vienna challenge. And Vienna challenge is a situation where the reproducible conditions are there and different drugs can be studied. So what was found that bilastine had a rapid onset of action within 1 hour and a long duration of action greater than 26 hours. Cetirizine was quite similar to bilastine, while fexofenadine was similar on day 1 but less effective on day 2, thereby indicating that fexofenadine had a shorter duration of action as compared to bilastine and often needs to be given twice daily, whereas bilastine can be given once daily. Bilastine, like cetirizine and fexofenadine, was found to be safe and very well tolerated in this study, which was done in 2010. So to end my discussion on antihistaminics, the take-home points from today's discussion are: bilastine is a potent, highly selective H1 antihistamine with anti-allergic, anti-inflammatory properties in vitro. It has a very rapid onset of action, so the maximum action can be seen within 1 hour itself with longer duration of action, so requiring only once daily dosing, and has very less sedation. And bilastine meets the current European Academy of Allergy and Clinical Immunology and allergic rhinitis and its impact of asthma criteria for medication use in the treatment of allergic rhinitis. So all in all, bilastine seems to be a very good molecule, and we have been using bilastine since last several months. And I think we'll discuss the use of bilastine in the clinical situation in the next part of this discussion. Over to you, Zog, sir.
Thank you, Sanjay. It's very nice of you to elaborate about this molecule in details. And just as always, there is a new film release. We always have new molecules coming, and we call them these days as new kid on the block. So the time will definitely tell us more about this particular molecule. We ourselves must gather more and more experience by using it in allergic rhinitis, allergic rhinoconjunctivitis, urticaria, and so on and so forth. And Dr. Moralwar is here now to share his experience about this molecule and his views about the role of antihistamines in the management of allergic rhinitis, urticaria, and conditions likewise. So, Dr. Moralwar, you can start with your presentation.
Yeah, thank you. Thank you, Joe. Yeah, good evening, friends from Pune and Kolhapur. I am pleased to share my experiences of bilastine with you. Few points will be repeated because all of us are talking about the single molecule. I will be discussing about the clinical cases in the management of allergic conditions. The first patient is a 6-year-old Alicia who was rushed to the doctor for pruritic rash on extremities, abdomen, and back. She had facial swelling and slight change in voice. She has been well except occasional rash, occasional nasal discharge, and itching of nose. In the past, she had intermittent rash which was treated with tropical creams. She has no history of asthma, but her father had asthma in childhood. Here, we can differentiate between the rash and angioedema. The difference is in rash, only skin is involved, while in angioedema, skin and subcutaneous tissue is also involved. So that is why there is a facial swelling, which Dr. Jog had pointed out in his cases. The differential diagnosis will be insect bite, papular urticaria, contact dermatitis, and rash resembling early erythema multiforme. The characteristics of the articular rash is it is acute in onset, It is associated with severe itching. It is transient in nature. Lesions are of various size and shape. Lesions are pale with papular center and they coalesce and blanch on pressure. What is very important to remember is skin is always intact and there is no epidermal break in urticaria. There are many causes of urticaria. The most common cause is viral infections. It also can occur in parasitic, bacterial, and fungal infection. Even physical stimuli like heat, cold, and pressure can cause urticaria. Even exercise and anxiety is known to cause rashes. There is condition known as C1 esterase inhibitor deficiency, which is very common in autoimmune disorders and lymphoproliferative disorders, especially thyroid disease, rheumatoid disease, type 1 diabetes, and celiac disease. Urticaria is very common during this thing. And food allergy and adverse reaction, Dr. Jog has already covered. As the case continues, Alisha's symptoms are of rash, swelling, and change in voice, suggest that a systemic reaction with angioedema. And I have just differentiated angioedema with ordinary rash. The treatment with antihistaminic is clearly indicated in this case. The treatment with antihistaminic will be a diagnostic as well as therapeutic. And these agents can relieve rash and itching both. She may require treatment with epinephrine or admission if pulmonary symptoms increase, as Dr. Jog has pointed out. The key factor in allergic response in such cases is interaction of allergen, that is antigen, with IgE and its receptor complex. This leads to activation of mast cells and basophil. There is a release of substance, including histamine, that causes allergic symptoms. WHO recommends its antihistaminics, second generation antihistaminics as a primary line of treatment in urticaria. Bilastine is more effective in limiting early allergic responses in urticaria, especially cutaneous wheal and flare. It is also very effective in cold urticarias. It is also used as a second line of treatment in resistant urticaria, especially in supratherapeutic doses. It is recommended that we can use 4 times the recommended dose of the off-label dose, and in spite of that, the medicine is very safe. It can be used especially in drivers or pilots or people who are very close to the moving machinery. It is very safe in these patients also. Let us see case number 2. This is 7 years Mahesh complains of a runny nose. His complaints includes sneezing, itchy throat, eye tearing. His mother complains of mouth breathing and loud snoring. Mother says his symptoms are worse during summer. They have tried various cold remedies with little or temporary success. History of mother having asthma is present, and there is a drop in attendance in school. That means his complaints are interfering with his day-to-day activities. On examination, his nasal terminates are edematous, pale blue, boggy, and coated with clear discharge. His examinations reveals conjunctival edema, eyes with tears, dark circles around eyes, and creases around the bridge of nose. Other systemic examinations are within normal limits. So he fits into a moderate intermittent rhinitis. So intermittent allergic rhinitis if the symptoms are less than 4 weeks, and persistent if they are more than 4 weeks. The differential diagnosis in this intermittent allergic rhinitis will be recurrent upper respiratory tract infection, vasomotor rhinitis, which is usually transient, non-allergic rhinitis, CSF rhinorrhea, sinusitis, as Dr. Jog has covered, and nasal foreign body. In this case, it is unilateral discharge is present, and even nasal polyps unilateral can give rise to similar complaint. While if you consider persistent rhinitis, then there are different differential diagnoses. Persistent rhinitis with symptoms suggestive of lower tract infection, asthma can be there. Or if there is early onset of persistent rhinitis, even from the neonatal period, then primary ciliary dyskinesia should be thought. If nasal polyps are present, especially in early age group, then cystic fibrosis should be ruled out, and even vaginal granulomatosis can present with similar complaint. The diagnosis of allergic rhinitis is based on characteristic symptoms and signs and responds to empirical treatment with an antihistaminic syrup or a nasal steroids. The formal diagnosis is also based on presence of an allergic specific IgE in serum or by positive epicutaneous skin test. It is easier to diagnose when seasonal symptoms are present or if single identifiable trigger is present. As far as management is concerned, allergen avoidance and environmental control is very important, as discussed by Dr. Joe. Systemic antihistaminics, decongestant, anticholinergic drugs. Dr. Natu has just covered the systemic antihistaminics. Nasal steroids. Immunotherapy and topical eye preparations are used for as tears. And the recent trend is yogas. Pranayams, asanas, meditations, kriyas, and dietary modifications are recommended in yoga. And we can refer to ENT person for if we think adenectomy, turbinectomy, septoplasty, or sinus surgery is helping him. So, if we consider types of rhinitis, it is episodic symptoms, mild symptoms with seasonal or perennial, or moderate to severe symptoms. And recommended treatment is given. But what is important is H1 antihistaminics are the base of treatment in each and every type of allergic rhinitis. Antihistaminics, if you consider, they are not structurally related to histamine. So they are not competitive antagonists of histamine binding H1 receptors, but they are inverse agonists rather than antagonists. H1 antihistaminics interfere with histamine's action on sensory neurons, small blood vessels, and smooth muscle cells, and they downregulate the allergic inflammation. If you consider belastin, it's a non-sedating, as Dr. Natu has already covered up, that it's a non-sedating, long-acting histamine agonistic, and it's an H1 receptor agonist affinity and no affinity to muscarinic receptors. 10 milligram of belastin, that is 4 ml oral solution once daily for the relief of symptoms of allergic rhinoconjunctivitis and urticaria is recommended. We can use it for even up to 3 months. I have used till 3 months, and some references are there that it can be used for a longer time also. The liquid oral preparation is available and it contains 2.5 milligram per ml. And what is important, that use it 1 hour before food and 2 hours after food, because food significantly reduces the oral bioavailability of belastin. If you consider tablet, the almost 30% reduction is there in absorption, and if you use syrup, at least 20% reduction is there. Especially they have data mentions that you don't use grape juice, and in fact, even any fruit juice will reduce the bioavailability of belastin. And PGP inhibitors should be avoided, like ketoconazole, erythromycin, cyclosporin, ritonavir, because they may increase the plasma levels of belastin and therefore increase the risk of adverse effects of belastin. I have experienced only mild headache following belastin. Otherwise, there are no other side effects. Few people have reported mild weakness and so on. Thank you for helping me to present this presentation to you.
Yes. Thank you, Dr. Prashant. It's very nice of you to give your personal experience and in the treatment of allergic rhinitis as well as urticaria. So we have already started getting plenty of questions from our listeners, who are more than 500 listeners around. And Dr. Sanjay, I have a question for you. And one of the listeners wants to know as to, lot many preparations of antihistaminics along with montelukast are present in the market. So many of us always say that the combination is not a rational one. However, there are many combinations. So why these combinations have come in the market, and what is your opinion about the combination of an antihistaminic along with montelukast?
The combinations are available, different types of combinations, and most of the times, unfortunately, they are not rational combinations. Especially in the case of this bilastine and montelukast, they do not go hand in hand for some reason regarding their pH, because they are of opposite pHs, and hence, if given together, they do not go hand in hand. I personally prefer to use separate drugs when they are required. Moreover, not each time both the drugs are required. Sometimes it is just the antihistamine which is required, and for no reason we need to use the leukotriene antagonist as well. So preferably, we should try to avoid these combinations for the pharmacological reasons as well as the practical clinical reasons.
Right. So the combination in a syrup form is unstable. Maybe, in the tablet form, there could be a biolayer between the two molecules, and the combination could be given, but definitely not in the syrup form, because it's not a stable combination. Thank you, Sanjay, for that answer. One of the listeners wants to know, Dr. Muralwar, he wants to know as to what is the earliest age at which we can start giving bilastine, and how long in a child with urticaria you can continue this particular molecule, bilastine?
Yes, I have used this molecule after 6 years of age in allergic rhinitis, but my patient's mother has given this medicine without advice to her younger child who was 4 years of age, thinking that this medicine is for cold, and nothing had happened. But I have not prescribed it below 6 years of age, and we can use it for a longer time because it's very safe. I have used it for 3 continuous months, especially whenever there is seasonal change. I have advised mothers to use this preparation so that allergic rhinitis symptoms don't occur. But when you use it for a very long time, especially in chronic urticarias or this thing, then you have to use this along with some other medications. And why this is important? Because this, when you are using for longer period, we have seen that these are the patients who have other comorbidities, autoimmune disorders, and they are also on some cyclosporine or immunomodulators. So this has no drug interaction. So this will be more useful. This molecule will be useful in such cases.
Okay, thank you. Thank you. And Dr. Sanjay, there is a question from one of our listeners as to what is the best way to consume this particular molecule, whether it is to be taken along with food or empty stomach, and what is your opinion about it?
The recommendations are very specific. It needs to be given on empty stomach at least 1 hour before food, or at least 2 hours after food, because food affects the bioavailability of this drug by 20 to 30%. So on empty stomach, 1 hour before food, or at least 2 hours after food.
Okay, so it is a molecule which is to be taken on empty stomach. Okay, that's good. Now, there are some questions about environmental control as a part of therapy in allergic rhinitis and urticaria. So I would like both of you to give your own opinion and experience as to how, when a parent is sitting in front of you and they say that as soon as this child, in the months of August or September, goes outside the house, starts sneezing, or another child, who is just coming back from the school, goes to the playground and then starts sneezing. So if there are parents who are in front of you, I would just like you to tell our listeners as to how you, in your practice, tell them about avoidance of allergens. So Dr. Muralwar, can I have your experience about avoidance of allergens?
What everybody has realized during this COVID period is wearing mask. So that is the best method to avoid allergens in the environment. But what I want to insist that even these known pollens or other agents have cross reactivity with so many other home internal environmental allergens. Like you can have food allergy, which is a cross reaction to the environmental pollens and so on. So the best method is to you wear mask or do testing. But if you are having a cross reactivities to internal environmental problems, so you should not get worried too much. But the identification of the allergen, and if it is a single allergen, it is the best, easiest method to avoid that.
Okay. And Sanjay, what is your opinion about avoidance
Yeah.
of allergens?
Yeah, so allergen avoidance is a very important means for prevention of these episodes of allergic rhinitis and asthma. And as we already discussed, the common indoor allergens are pets or rodents and cockroaches, dust mites, and molds. And dust mites is one of the commonest, which is like ubiquitous. Now, sensitivity to these allergens can be detected by sensitization determination by skin prick tests or specific IgE levels from the blood. However, after that, determining the sensitivity, we have to find out whether there is significant exposure occurring to that particular allergen. And then once that is identified, we should try to avoid that allergen. Now, it is easier said than done because practical problems are there are multiple allergens involved in one patient most of the times. And the interventions, though sometimes easy, are not very commonly followed by the patients many times. So what are the common interventions which can be done? For example, if there are molds growing in the house, then avoidance of these seepages or taking care of the leakages is very important. Maintaining a dry environment is very important. As far as dust mites are concerned, again, decreasing the humidity in the surroundings is important. Covering the beds and the pillows in a casing is also important. Vacuuming regularly is also important. And wet mopping and avoiding the jhadu is very important because they tend to increase the allergen exposure. In addition, as sir has already pointed out, the irritants are easily avoidable. For example, the agarbattis and coils, as well as the very strong perfumes and deodorants, which are very in vogue nowadays, they can also cause a lot of irritation. And these measures, if followed, can decrease the episodes of these conditions like allergic rhinitis to a substantial effect. Unfortunately, as I said, easier said than done.
Right, right. Thank you, Sanjay. I will just add certain points. As soon as you enter into the house, please see that your shoes, the footwear are kept outside the house because they may carry allergens. If possible, use an air conditioner inside. Also remember that, as I told you about the perfumes used by the parents, beware of that. Even the floor cleaners, beware of that. And the pets, particularly the dogs and the cats, they should be out of the bedroom. I always say that the only pet allowed in the bedroom is the husband. So he's the only one who can be allowed in the bedroom. No other pets inside. Okay. And if you find cockroaches, many of us have a habit of crushing the cockroach. Okay. They will take a pleasure, maybe a sadistic pleasure of crushing the cockroach. Okay. So that particular crushing will release the allergens into the atmosphere. So please remember, you don't crush the cockroach. Even if you want to remove, use some other innovative means of removing the cockroaches. Okay, but don't crush it. There are many points about the dogs and the cats which we will discuss at some other meeting, but some of these are important. And the dust mite is a very, very notorious one because it doesn't get destroyed at warm water. It needs about 130 degrees Celsius temperature to get destroyed. And now when the schools reopen, the parents should remember that they should not make the child stand in front on the scooter, because many times the exhaust of the trucks, it comes from the front and impinges on the respiratory system of the child. And you already mentioned about the mosquito coils in the evening and the agarbattis, which are also known allergens. So I think our listeners will give the health education to the parents about allergen avoidance properly. Is there anything else from your side, Dr. Moralwar, which you would like to tell our listeners? You can give your last word, and then Dr. Sanjay, so that I can sum up after both of you give your own comments. So, Dr. Moralwar, if you have anything, you can just say.
I want to say everything under the sun, including sun, can cause allergy. So it's very difficult to bring allergic problems under control, but we should manage to reduce it.
Right, right. I agree with you, because as I said earlier, you can control control the allergy, you cannot cure that. And many times I remember, a person eats a fish, for example. In the first instance, nothing happens, but it is the re-exposure to the same allergen which creates problem. So he goes to some sea beach at Alibag, and then he consumes some sea fish or a shellfish, and then he starts getting an allergic problem. So it is the re-exposure to the same allergen which is a problem, and that's why one should be aware of what is the problem. Sanjay, what is your take about today's discussion?
Yeah, so as Morulak sir has said, allergic problems are very common, ubiquitous, and this new molecule, bilastine, seems to be a very promising solution to many of the problems of these allergies. We have been using this since last few months, and let us see how this molecule performs over the duration of next few months, so that we can use this as the first line in the management of allergic conditions.
Okay, that's very great. I many times feel that now I keep going to the medical college, and Sanjay, you are also in the medical college. We must have this allergic rhinitis as a full case for our candidate.
Absolutely.
Many times we keep discussing about rheumatic hearts and viscous arthritis syndrome and others, which have no practical relevance in our day-to-day practice. But we must let our students know lot many things about antihistamines. We have learned a lot about this particular molecule, which has a very, very fast onset of action within 30 minutes. The onset of action is fast. The action lasts for almost 26 hours. It is a safe molecule because it does not cross the blood-brain barrier, and that's why it is non-sedating. It does not produce any QT prolongation. It can be safely given in patients who have liver or renal disorders, and it has a good backing from the international bodies like the European academies and the area guidelines and others, and that's why it's a very, very promising molecule. And being once in a day, the adherence also is very good, so that parents remember that I have to give it only once in a day. So that's something which is great. And non-sedating is very important. You imagine that you take some antihistaminic and then you have to see the 100 patients in front of you and 50 medical representatives, and you are drowsy. You can imagine. So a non-sedating molecule has its own place. I would just say that now, because of COVID, and as Dr. Moralwar said, people have started using the mask, the respiratory infections have gone down, and we don't get these viral infections and the flu and others. So the days are that we have to now turn on to daytime pediatricians and concentrate more on growth and development, nutrition advice, and allergy, and so on and so forth. So it's important that our friends from Kolhapur and surrounding areas, they start learning more about the cold pediatrics. Of course, infectious diseases and intensive care we have been doing all throughout these years, but now we will have to concentrate on some of these and become daytime pediatricians. And then you have to know a lot about these allergic disorders. So with that, I thank all our listeners for participating in a large number. And I also thank Dr. Moralwar and Dr. Sanjay Nathu for giving excellent presentations and excellent answers to the questions by the audience. Thank you once again. Thank you. Thank you.
Thank you, sir. Thank you, sir.
Thank you.